Imagine this. A seemingly healthy young person, vibrant, full of life, suddenly collapses without warning. No prior symptoms, no obvious illness, just a sudden devastating cardiac event. What if I told you that in many of these heart-wrenching cases, the subtle clues, the silent warnings were there all along, hidden in plain sight on a routine diagnostic test that many of us take for granted? Today, we're taking a deep dive into that fascinating and, frankly, life-saving world where a closer look at the heart's electrical language can unveil these hidden dangers. It's truly incredible what a few squiggly lines on a piece of paper can tell us, really. But before we truly plunge into today's deep dive, we want to extend a very special thank you to London Heartbeats Academy UK. Their invaluable educational support has really helped make this exploration possible. For anyone out there looking to deepen their understanding of cardiology or, well, any field really, they offer over 150 popular courses. You can find them on social media, Facebook, Instagram, and YouTube for free regular updates. That way you ensure you never miss out on future amazing discussions and insights like this one. And for those who want to take their learning even further, subscribing to their higher level YouTube membership gives you early access to educational videos and even personal chats and guidance sessions. They're an incredible resource for learners like you.
That's precisely what we're here to do. The electrocardiogram, or ECG, it's an absolute cornerstone of modern cardiology, no question. It's rapid, non-invasive, widely accessible, yet it holds secrets. Some of its patterns are incredibly subtle, quite atypical, and they can pose real diagnostic challenges, even for experienced clinicians. So our mission today is to extract the most important nuggets of knowledge from this complex material. We want to highlight their crucial clinical context, their characteristic findings, and the vital implications for diagnosis and management. These conditions, they span a wide range, from acute life-threatening emergencies that demand immediate attention to chronic electrical disorders needing careful long-term monitoring. Ultimately, we aim to enhance your awareness and recognition of these unique conditions, improving patient outcomes through timely and accurate diagnosis. Get ready for some serious aha moments, because the insights hidden in these ECGs are truly remarkable.
I'm ready to unpack this, and I know our listener is too. Let's get started with a powerful real-world example right off the bat. Imagine this scenario. A 10-year-old girl, seemingly the picture of health active, vibrant, full of energy, suddenly collapses during a school swimming lesson. There were no prior symptoms, no hint of illness, and her parents are, understandably, completely baffled. When the emergency team performs an ECG, the result sends a chill down their spines. A significantly prolonged QTC interval measuring over 500 milliseconds. What's even more striking is that further investigation reveals she also has congenital, profound, bilateral sensorineural hearing loss, a condition that had previously been attributed to other causes entirely. This combination, once connected, points directly to a rare but devastating condition called Jervell and Lange-Nielsen syndrome.
This case is absolutely critical because it highlights a profound truth in medicine: the need to connect seemingly unrelated symptoms. On their own, hearing loss and a fainting spell might be investigated separately, right? But when you see that combination of congenital deafness and a significantly prolonged QT interval on an ECG, it's a textbook example of Jervell and Lange-Nielsen syndrome. Timely recognition here isn't just important, it's literally life-saving. It guides clinicians to aggressive management strategies that can prevent fatal arrhythmias. It's like finding two puzzle pieces that, when put together, reveal a completely hidden picture. It's quite striking. 2-second quiet.
Okay, let's begin our deep dive then with long QT syndrome, often referred to simply as LQTS. You mentioned it in our opening case, and it's a condition where the heart's electrical system essentially takes, well, a little too long to recharge between beats. What exactly does that mean, or the heart's rhythm?
That's a perfect way to put it, actually. At its core, LQTS is a genetic heart condition. It affects how the heart's electrical system resets itself after each beat. Think of your heart's cells like tiny batteries that need to quickly discharge and then recharge to prepare for the next beat, right? In LQTS, this recharging phase, which we call ventricular repolarization, is abnormally prolonged. On an ECG, this shows up as a stretched-out QT interval. It's not super common, affecting about 1 in 2,000 to 1 in 2,500 individuals. Historically, researchers first started linking sudden cardiac death to prolonged QT intervals back in the mid-1950s. They noticed it particularly in deaf individuals, which later led to understanding different types or variants of the syndrome. It wasn't until the 1990s that specific genes responsible for these electrical issues were identified, and now we know of at least 17 genes that can play a role.
Right.
So it's quite diverse in its genetic origins.
So if we zoom into a cellular level, what's actually happening inside these heart cells that causes this prolonged recharge or reset time?
Okay, so the primary cause boils down to faulty electrical gates in the heart cells. These are tiny structures called ion channels, and they're responsible for the precise flow of electrically charged particles, like potassium and sodium, in and out of the cell. In about 95% of LQTS cases, the problem is with the potassium channels. Imagine these channels are like gates that should open and close at specific times to let potassium flow out and help the cell reset. In most LQTS types, these potassium gates don't open properly or close too slowly, leading to a loss of function. This means the electrical reset takes too long. But here's where it gets particularly intriguing. One specific type, LQTS3, involves a different kind of malfunction. It's a gain-of-function mutation in the sodium channels. In this case, the sodium gates stay open a little too long, allowing too much sodium in, which also extends the action potential duration. All these alterations ultimately extend the time it takes for the heart muscle to repolarize, making individuals incredibly susceptible to dangerous, rapid, chaotic heart rhythms, especially a type called torsades de pointe, or TDP.
That makes a lot of sense. So, what does this mean for patients? What symptoms should someone or, their family be looking out for that might suggest LQTS?
Well, the clinical picture can be quite varied. A large study of over 600 LQTS patients found that, surprisingly, only about 27% were symptomatic, meaning many people might carry the genetic predisposition without realizing it until, well, a critical event happens. When symptoms do appear, they often begin around 12 years of age. The most common manifestation is syncope, or fainting, occurring in about 60% of untreated patients. Now, what's crucial to understand is that syncope in LQTS is quite distinct. It's often very sudden, without any of the usual warning signs like feeling lightheaded or heart racing or dizzy. Instead, episodes might be associated with apnea, a temporary stop in breathing, or even a bluish tint to the skin, and sometimes seizure-like movements. This just underscores the absolute importance of a detailed personal and family history. If there's any family history of sudden death, unexplained drownings, or even mysterious car accidents, it should raise a red flag immediately.
So, the ECG is truly the cornerstone of diagnosis then. How exactly do doctors use it to pinpoint LQTS, especially with all these nuances we're talking about?
You're absolutely right. The ECG is foundational. The first step is always to rule out acquired causes, like certain medications that can prolong the QT interval. That's actually a very common cause of this phenomenon. Often, serial ECGs, meaning multiple readings over time, are needed for accurate diagnosis. The hallmark sign is a prolonged QTC interval. The C stands for corrected, because the QT interval naturally changes with heart rate, so we use formulas to adjust it. We typically measure from the start of the QRS complex, that's the heart's main contraction, to the very end of the T wave, which represents the heart's electrical reset. We usually look at leads 2, V2, or V3, averaging it over 3 Ds. A QTC over 460 milliseconds in females and 450 milliseconds in males is a key indicator. Now, what's fascinating here is that while a standard ECG is vital, a 24-hour Holter monitor can also be incredibly helpful. This small, portable device records your heart's electrical activity over a full day, assessing dynamic changes in the QTC, especially during sleep or recovery. Other suggestive ECG findings include inverted T waves, T wave notching, and something called T wave alternans, or TWAs. TWAs are a subtle beat-to-beat variation in the shape or amplitude of the T wave, and they are a significant warning sign, alerting clinicians to a heightened risk of lethal arrhythmias. Also, brief pauses in the heart's rhythm, known as sinus pauses, can be an alarming sign, particularly in the LQT3 subtype. The most common life-threatening arrhythmia we see is torsades de pointe, or TDP, which literally means twisting of the points. It's a rapid polymorphic ventricular tachycardia that looks like a ribbon twisting around the baseline on the ECG, often triggered by a long, short sequence of heartbeats. Very distinct pattern.
Okay, beyond the standard ECG, what other tests help pinpoint LQTS and maybe guide treatment?
Right, so while a 24-hour Holter can detect transient QT prolongation, it's not considered the single gold standard. For long-term monitoring, implantable loop recorders can be invaluable. They quietly track heart activity for extended periods. There are also specific challenge tests, like an adrenaline challenge test or a mental stress test, or even just doing an ECG when a patient goes from lying down to standing up. But these generally have lower diagnostic value compared to the core ECG findings in genetic testing. Speaking of which, genetic testing is absolutely crucial. It's strongly recommended for patients with a high Schwartz score. That's a scoring system doctors use to assess the likelihood of LQTS based on symptoms and ECG findings, or for asymptomatic individuals with a very prolonged QTC, and definitely for relatives of someone already diagnosed. This helps confirm the diagnosis and identify the specific genetic subtype, which can really influence treatment decisions.
So, how do doctors pull all this complex information together for a definitive diagnosis? Is there a kind of checklist they use?
Exactly. There are clear guidelines. An expert consensus statement on inherited arrhythmias outlines specific criteria. You can diagnose LQTS if a patient has a Schwartz score of 3.5 or higher and no other secondary causes like medication are found, or if their QTC interval is 500 milliseconds or more on repeated ECGs. Alternatively, a QTC between 480 and 499 milliseconds, coupled with unexplained fainting episodes, can also lead to a diagnosis. The Schwartz score itself is a point-based system. It considers clinical signs like fainting and deafness, and various ECG features like the QTC duration, the presence of T-wave alternans, or notched T-waves. More recent guidelines, like those from the European Society of Cardiology, even give extra weight to a resting QTC of 480 milliseconds or more and the presence of a confirmed genetic mutation. It really emphasizes the power of those genetic insights.
Okay, so once diagnosed, what's the path forward for managing LQTS? What do patients and their families really need to know about living with this condition?
Management really centers on risk stratification, figuring out who's at highest risk, and making crucial lifestyle adjustments. Invasive electrophysiological studies aren't typically the first step. Instead, we rely on the clinical picture, ECGs, and genetic information to identify those at highest risk for sudden cardiac death. Beta blockers are the absolute mainstay of therapy. They significantly reduce the risk of cardiac events by up to 60% and are generally recommended for all diagnosed patients. Beyond medication, lifestyle modifications are vital. For example, individuals with the LQT2 subtype should particularly avoid cold water immersion. And all symptomatic patients are usually advised to avoid competitive sports. Even asymptomatic individuals with confirmed genetic mutations need careful counseling. Other treatments exist, like potassium channel openers for LQT2 or mexiletine and ranolazine for those who can't tolerate beta blockers. For very high-risk patients, those who've had a cardiac arrest or keep fainting despite optimal therapy, an implantable cardioverter defibrillator, or ICD, is usually indicated. These devices can detect dangerous rhythms and deliver a life-saving shock. Pacemakers can help with very slow heart rates that might trigger QT prolongation. And in really tough, refractory cases, a procedure called left cardiac sympathetic denervation can be an option to reduce arrhythmia risk.